and even anytime to a practitioner. So, Dr. Harshvardhan is a very prolific teacher and teaches Anesthesia Workstation really very excellently. I'm sure you will agree with me once that webinar is over. So, learn to use anesthesia machine with confidence. Join this webinar to master the basics of Anesthesia Workstation. As such, Anesthesia Workstation is a very extensive topic, but we will stick to only basics of Anesthesia Workstation and troubleshooting of Anesthesia Workstation. Anybody has any doubts or any questions to be asked, we can take it later on at the end of the session. And intermittently, if you feel, you can put it in a Q&A box. Dr. Harshvardhan Tikle is a professor additional in Nair Hospital, and he is one of the person in Mumbai who can really teach anesthesia workstation excellently. So I welcome Dr. Harshvardhan Tikle for handover of the session to him. So welcome, Dr. Harshvardhan.
Thank you very much, Yogita ma'am. Uh, Good evening, everyone. Uh, I will be taking anesthesia workstation, and as Madam has already said, it's a very extensive topic. Usually, one day's CME is done on the workstation. So I will try to compress it in say around 1.5 hours to tell you what are the basics of the anesthesia workstation and how do we go about using it and what future holds for us uh, after a few years of practice. So I'll start with my presentation. So with a brief history, in 1846, first time ether anesthesia was given, and for next 50 years, after the first successful demonstration, the attempts were limited only to open ether anesthesia, and no other system was developed to deliver safe anesthesia to the patient. Till 1912, nothing happened when James Taylor Watmey of New York, he decided to make a machine with anesthesia with oxygen cylinder and nitrous oxide with some reducing valve, and which was modified by Henry Boyles in 1917, and which became very popular, and that's what we call it now, the Boyles machine. It was manufactured by the Coxter Mecha company, and till date, the basic components of the machine or any workstation are same as that have been introduced by HEG Boyle, and all subsequent changes are mainly to improve the patient safety and the personal safety in the operating room. Here are a few important historical landmarks in development of the workstation. So the CO2 absorber was first used in 1921, flow meters in 1927, vaporizers appeared in 1930. By 57, we had tech vaporizers. A circle absorption system was introduced in the 30s. Index system for pin index system was there in 1952. And the Bodox seal to attach emergency cylinders was introduced in 1958. Till that time, generally big cylinders were used with the Adams reducing valve and that were connected with the pin index system to the machine. So this is what the machine looked in the early 1960s. A very basic machine. You had cylinders, flow meters, internal piping, vaporizer, a pressure relief valve, and a common gas outlet which could be used for open as well as a closed breathing system. So that was the basic anesthesia machine, which is still there. And now we have come to, in the last 60 years, we have now come to the modern integrated anesthesia machine. Till 1960, from 1960 to 1990, it was still called the Boyle's apparatus or Boyle's machine. But after 1990, it has been now renamed as anesthesia workstation or anesthesia care station. It's designed for complete anesthesia and respiratory gas delivery along with the monitoring system. Nowadays, it combines advanced ventilation features which are available with the ICU ventilators, a gas delivery system for anesthesia agent, different vaporizing units, and patient monitoring and information management system to be has been integrated into the anesthesia workstation. So it has now become a complete package for future where data can be transferred easily and downloaded easily for us to summarize and better our own performance every time. The first five components have remained same throughout the evolution of this workstation. The gas supply and delivery to the machine through a bulk source. It was cylinders or right now liquid oxygen or other bulk storage devices. A pressure regulating and reducing valve along with the pressure gauges to know the pressure. Flow meters from conventional to electronic, everything is there. Vaporizers, right now from Tech 4 to Tech 7 to cassettes, everything is same. Most of them are planar vaporizer. The ventilator and the breathing system we have developed from uh, a pressure-driven system to a volume delivery system to a combination of both flow and pressure-generating system. The monitors and the scavenging system has been recently introduced, and the monitors right now include from the basic standard monitors that are required by ISA or ASA and to the advanced monitoring system that is required for attending to any critically morbid patient or a very young patient. So everything can be used in this machine. The new machine uses advanced electronic and software technology to offer these capabilities of ventilation, monitoring, to deliver low flow, very low flow anesthesia, and to use closed loop anesthesia system for delivery of anesthesia. They offer integrated monitoring and recording facilities and have a seamless integration with, if required, with the anesthesia information system or the hospital information management system. So all the data can be stored properly and used for all future analysis and advance. Appropriate use results in enhanced safety and ergonomy of the anesthesia and delivery. Now, we generally consider anesthesia to be compared with aviation, and that's what our modern anesthesia machine has become. A modern modular anesthesia machine can be compared to a multi-role aircraft, which can be specifically designed for a mission with a specific requirement as a case may require. So you can tailor it from for a very simple job to a very complex monitoring system for a very critically ill patient. Anything can be added or deleted as per the requirement. So this is how the workstation looks today. So whatever you see of this is mainly electronic interfaces, modular monitoring system, screens for monitor, airway monitoring system, ventilators, which is integrated inside, and all the other systems that are required for us to deliver safe anesthesia. Now, what are the functions of this machine? Well, it has only four functions: provide oxygen, accurately mix anesthetic gases and vapor, enable patient ventilation, and minimize the risk to patients and staff. Now, modular anesthesia system has made workstation a versatile tool to deal with wide range of patients, both in terms of age and in terms of comorbidity. So when we add, say, non-invasive cardiac output monitoring, we can use it for patients who have very less cardiac output or at a high risk for having intraoperative cardiac failure. So we can monitor their function, we can decide what drugs needs to be used for them and when that drug needs to be used for them. Other additional important components in new workstation is a master switch. There is a single switch for both pneumatic and electrical parts. So once you start the machine, both the electrical displays and the pneumatic system starts. There is a power failure indicator and a battery backup reserved for 30 to 60 minutes. It has multiple electrical outlets for your monitors and other added devices that you would like to add to the machine, say infusion pump or something. Circuit breakers to prevent damage due to power surge, as these are microprocessor controlled machines most of the time. And a high power surge usually leads to damage in the system and may prevent an optimal use of the machine. On the backside, there are data communication and transfer ports from where the data can be transferred to the hospital system or any recording system. So we can easily transfer it and print it out and give it as an intraoperative charge to the patient. Now, what are the objectives of this interaction? Basically, to understand what are the parts of anesthesia workstation, we need to broadly understand the pressure system and components, identify the safety features that are incorporated in the workstations, and gain insight into what future might hold for us as far as the workstations are concerned. So I will be covering only these four things. Uh, let's start with uh, the functions of the anesthesia workstation. Usually, it receives medical gas from a high pressure system and converts it into a low pressure suitable for delivery of anesthesia. It provides waste anesthesia gas scavenging for patient and operational theatre personnel safety. It provides means to monitor vital parameters, both standard and advanced, as required during the conduct of anesthesia. And it provides for information and data management. Now, basically, it's divided into three parts. The high pressure system, which receives gas from cylinder or any bulk source which is outside the operation theater and makes it more constant at around 60 psi. Intermediate pressure system, which receives gas from the first stage regulator or hospital pipeline and delivers it up to the flow meter and oxygen flush and other oxygen failure devices in between. And a low pressure system, which takes gases from the flow meter and the second stage reducing valve and goes up to the patient, which is at a very less pressure, around 1 psig or at least 5 to 10 centimeters of water. What are the components? In high pressure system, you have a hanger yoke system, a Borden pressure gauge, and a first stage reducing valve. High pressure system is used only by the emergency cylinder, which is attached to the anesthesia machine. And the complete high pressure system is a single assembly made into a one part. It does have different parts in it, but they are used to form a single component in the machine. Intermediate pressure system consists of your pipeline uh, from the bulk source, the pipeline inlet system, pressure indicators, the piping, the wall-mounted gas outlet, master switch, oxygen failure devices, oxygen flush, the second stage reducing valve. All this are inside the machine and we cannot see them from inside. Most of this are from in the inside of the machine, and in newer anesthesia workstations, we cannot open them because of the company policy. Otherwise, in older boil machine, we could see those pipes and we could actually look at what actually was the basic anatomical diagram of the machine. The low pressure system starts from the rotameters. It has a unidirectional check valve or a pin valve. You have pressure relief device on the back bar, a vaporizer mounting device with unidirectional valve, and a common gas outlet, from where the gas can be either directed to the open system, like the Mapleson system, or to the closed circuit and ventilator. Now, medical gas pipe system or a bulk storage system. This, I think, uh, many books put it into a low pressure system, but it is a part of a high pressure system because by concept, any high pressure system is up to the first reducing valve. So first stage reducing valve in the bulk storage is near the bulk storage where it is done. Okay, the storage is done at a remote place. Oxygen is generally stored as liquid oxygen or maybe in a pressurized gas from the PSA system. And other medical grade air and nitrous oxide is stored as pressurized gas. Now, except nitrous, which comes in bank, which you will see later, others are supplied to which is supplied only to the operations route. Other gases and vacuum can be supplied by pipeline to all parts of the hospital for use. So the pipeline system usually has a very variable pressure on what the amount of usage is right now in the system. Again, as I said, all gases are stored at high pressure. MGPS decreases the pressure to around 40 to 60 psig. and it is done near the source. So if you have seen a liquid oxygen tank, just before the vaporizer, you will see that there is a pressure reducing valve which reduces the pressure of that liquid oxygen and sends it through the heating system to the pipeline. For emergency condition, when there is a system dysfunction, the workstation has a backup of oxygen cylinder attached to it. Usually a Type E cylinder is attached. And since MGPS, the first stage reducing valve is at the storage facility, essentially the pipeline becomes the intermediate pressure system and the cylinder becomes the high pressure system inside the operation theater. Now the pipeline is usually made of a high tensile copper alloy and is color coded for each gas and vacuum. The tensile strength is measured to around 4 to 5 times that of the operational pressure of the gas that it is supplying to the hospital. Now this is MGPS. As you can see, our figure is for the nitrous oxide, and what you see on the just above the cylinder is the pressure reducing valve, and in between the two banks is the switching mechanism. So that once one bank is empty, the other one is automatically switched on. Okay, and same is for oxygen for smaller hospitals. So same thing can be used, but in our hospitals and bigger hospitals, generally we have liquid oxygen. The MTPS uh, reduces pressure to around 50 to 60 psig, which is slightly higher than the valve of the regulator valve of the machine, which reduces it to 40 psig. Now, this ensures that the piped gas is used preferentially and the one-way valve on the hanger yoke remains closed when the cylinder is empty, so that there is no transferring of gases into the cylinder. Now, this is a universal color coding and how the gas is supplied inside the operation theater. Now, oxygen and nitrous are usually colored yellow. The shoulders of those pipes will be white and blue, respectively. Medical and surgical grade air for pneumatic machines will be colored blue with white and black shoulders. Vacuum will also be blue with yellow shoulders on it. And for scavenging, which is a low pressure system, again, there will be a yellow line with blue and yellow shoulders coloring the pipeline. On the other photo, you see actually the pipeline coming inside the operation theater, and each gas has its own pressure indicator. So the pipeline pressure is already indicated, and every time before entering operation theater, it's generally mandatory that somebody should check what the pressure in the pipeline is, because the pressure itself decides many of the safety features in the anesthesia machine. So if there is a crossover or if there is some changes in the pressure, most of the systems may not function appropriately in the anesthesia machine. Now, once the pipeline enters into the operation theater, each gas has a specific wall mount. Now, it can be anything from a Schroeder's socket or a quick coupling device with any geometrical or any shape designed to it. And correspondingly, towards the machine end, it would have a DISS, that is diameter index safety system, or a non-interchangeable screw. Now, this is how the assembly is. You can see that uh, there are four different pipes which are color coded. Oxygen is usually supplied as white. Uh, Nitrous oxide is blue. Medical air is usually black with white strips, and vacuum hose is usually yellow in color. So this is an international standard which is used for all the pipeline systems. As you can see, there are different screw thread mechanisms on the each end of the machine and a different probe on each the other ends of the machine, which are specific for those gases. Now, gas inlet into the machine. Now, as I said, there is something called NIST or DISS system, which merges the pipeline into the anesthesia workstation. Now, actually, it's a misnomer because the screw threads are all the same. What is different is the part which you are seeing protruding on the upper figure, which is different for each gas and has a special receptacle. Unless and until that fits into the machine, the gas will not flow. So this is a safety mechanism that is used. So they have uniquely designed projected heads and color-coded caps to connect to the machine to prevent any mismatch during connection. As I said, the hoses are also color-coded, so we can identify which gas and where we have to attach on the machine. As I said, hanger yoke assembly, it basically has 4 or 5 parts. It has a retaining screw or a clamp, nipple or a receptacle, a pin system for safety, which has 2 pins, uh, which are arranged differently for all the gases. Basically, it's 2 and 5 for oxygen, 3, 5 for nitrous oxide, which are basically cylinders that are mounted. It has a unidirectional check valve, a Boden's pressure gauge, and first stage pressure reducing valve. So this is how generally a pin index safety is done. So you have a retaining screw which clamps the cylinder, which has uh, the nipple goes into the depression into the uh, stem of the cylinder, and the pins, which are 4 millimeters in diameter and 6 millimeters in length, will align with the depression into the thread so that you can properly assemble the machine. Uh, an offering seal, which is called a Bodox seal, is used for a tight connection between the anesthesia cylinders and the machine. This is how a unidirectional check valve is usually working. As soon as you open the cylinder, the gas at a high pressure will displace the diaphragm and let the gas into the anesthesia machine. Or if the cylinder becomes empty and there is an alternate source, the pressure in the pipeline will shift the diaphragm down and stop gas from flowing into the cylinder. Each gas has its own pressure gauge, which has readings written on it, which range from uh, around 500 to 2000 psig. Uh, so depending on the type of cylinders that you want to use, it is there. Same way, the reading is written in kilopascals also, and these are specific for each and every gas. As you can see in the figure, I have taken it from an old machine. Once you open up, just after the Boden's pressure gauge, the gas has passed. What you see is the pressure regulator valve. This is the first stage pressure reducing valve. In all the anesthesia machine where piped gas is used, this acts as a redundant safety mechanism that if there is too much of pressure in the pipeline, this regulator will again bring it back to a intermediate pressure. Now coming to the intermediate pressure system, it starts after the first stage reducing valve and goes right up to the flow meter. The main features of this system are the hypoxia prevention devices that are incorporated into the machine, like your oxygen failure alarm, like Ritchie's whistle or uh, oxygen shut-off valve. So all these shut-off valves are present in the intermediate pressure system. What are the safety devices in this intermediate pressure system? Uh, the machine will always give you an alarm when there is a loss of pressure for oxygen below 50 psig. It's a high priority, non-silenceable alarm, so it will blare till the pressure is not reverted back to the normal. And workstations are designed in ways so that the oxygen concentration never falls below 19%. So there is a fail-safe valve which is prevent in the gas line of nitrous oxide flow meter. And this is controlled by the oxygen supply source. So if the pressure of oxygen is more than 45 psig, then only, or 60 psig, then only the nitrous oxide will flow. This valve is usually of two types. We will discuss it later, but it can either shut off the gas supply directly for nitrous oxide, or it can proportionally decrease the supply of gas. When the pressure of oxygen falls, it will proportionally decrease the amount of nitrous which is supplied to the patient. Right now, I would like to mention that most of this master slave mechanism are only coupled with oxygen and nitrous and not with any other gases. So in case of failure of system, we can still use medical gas till the time we are very sure that there is no crossover in the pipeline. So if there is a crossover in the pipeline, then we don't have any option. We'll have to take off all the pipelines down and use the emergency oxygen cylinder. In that case, we never use nitrous oxide. Auxiliary oxygen supply and oxygen flush are also part of this system. Now, there are two types of fail-safe system that are used. One is a pressure sensor shut-off valve, which is all and none. So as soon as the pressure of oxygen goes below 25 psig, nitrous oxide will be completely cut off from the machine. And oxygen failure safety device, which is a proportioning device. So in that case, as the pressure decreases for oxygen, say from 60 to 40, the pressure for nitrous is also decreased to the same level, up to around 20 psig, when the pressure will be so low that the nitrous will be completely shut off from the system and no mixture of anesthetic agents will be delivered to the patient. This all is to prevent hypoxia in the patient, but this has a very serious limitation. So these are all pressure dependent and can still deliver hypoxic mixture in case there is a gas, so crossover of the gases in the pipeline, or raw gas is present in the pipeline or in the cylinder. So in these two cases, we cannot do anything. The only savior in this are the advanced monitoring system, which are like upstream of the flow meter. So only those can actually come to our help. It involves only two gases, as I said earlier, oxygen and nitrous, and they are clubbed under master and slave, where the main determinant of the flow in the machine is the pressure of oxygen. And this is the main limitation, that it is pressure and not the content of the pipeline that is uh, the feature of safety. As I said, prevents hypoxia occurring upstream of the machine circuit, but it does not prevent hypoxia due to pipeline crossover or a wrong gas in the supply source. And it is completely dependent on pressure and not on the content of the pipeline. The low pressure system will start from the flow meter to the common gas outlet. All modern workstations have a second stage pressure reducing valve just before the flow meter knob, which decreases the pressure of gases to less than 30 psig at the flow meter. To be very precise, it decreases the pressure of oxygen to 14 psig and to that of nitrous to around 26 to 28 psig. The flow meter also has a pin valve system in conventional rotameters and a computer controlled flow sensor in hybrid and electronic flow meters. Now, this further decreases the pressure that is leaving the gas from the flow meter to around less than 1 psig. Usually, it is around 5 to 10 centimeters of water that is used into the breathing circuit and given to the patient. Now, one of the key safety features in this system is the link 25, which is activated when nitrous oxide flow is initiated. Other gases are not linked to the system, so their operations are independent of the link 25. Now coming to the flow meters, they can be conventional, which you can see on the top, which consists of tubes for oxygen, nitrous, and air. They're called Hawk tubes. They are anti-static in nature. They are sealed with napron seal. They have a stop at top and bottom. And in older machines, because of the minimal mandatory flow which is required, the oxygen flow stops just at around 200 ml. So minimum around 200 to 250 ml bias flow, which is always there in the oxygen. Then we have got hybrid flow meters, which usually give you a digital reading, but you can turn them on with the rotatory knob, which are again color coded in most of the machines, and they are physically different from each other. The oxygen is protruding more outside, has large fluted end, so you can touch it and feel it. Digital flow meters are most common on newer workstations that even we are using, like the Advanced CS2. So in that selection of gas, it's display for the total gas flow, the percentage of mixture, all is provided through a digital interface. We can select what gas mixture we want. Everything can be done through a digital interface only. So we don't have to really uh, move any rotatory knobs in this system. So this is how a digital system actually looks like. So you have a total gas flow which you can select at around whatever you want, 2 liters when you are doing ventilator based mechanical ventilation, or you can do use 8 to 10 liters if you want it on a manual setup. Then you can decide the function, how much percentage of oxygen you want. And from the anesthesia gas selection, you can select what gases you want. You want air, oxygen mixture, you want oxygen, nitrous oxide, whatever you want, you can digitally select it. Additional information like the fraction of inspired gas is also displayed on the machine. Coming to the Link 25 system, now it's a pneumo-mechanical system, as I said earlier, because it has both the pressure as well as a mechanical linkage. And it maintains a constant ratio of 30% oxygen when nitrous oxide is used as a mixture of anesthetic gas. Now, how does it actually does it? As I told you earlier, the second stage pressure regulator will reduce the oxygen pressure to 14 psig and nitrous oxide to around 26 psig. And the sprockets which are there on the nitrous oxide knob are smaller. They are around 14 and there are 28 teeth on the oxygen. So every one rotation for nitrous will decrease or increase the by oxygen concentration by the 30%. So this is how it usually works. And the minimal gas flow which is allowed in this system is around 500 ml. Now coming to what happens after the flow meter, usually from the flow meter, the gases travel via backbar assembly to the common gas output. In most of the new machines, we don't see a conventional backbar, but there are two important things on the backbar which we have to remember. One is the unidirectional valve, and second is, as I've shown you here, two vaporizers. So two vaporizer mounts are present for each vaporizer. So they are one-way valves which are there on that mount. So and the Selectech technology or Selectech mechanism is there on that back bar. So you can use only one vaporizer at any given time. Now, vaporizers are generally high resistance metal chambers that hold anesthetic agent in liquid form and are vaporized when put to use. Now, most of the vaporizers are variable bypass with flow over the wick that creates saturated vapor before joining the gas. There is usually a splitting ratio. The fresh gas, part of the fresh gas is going into the vaporizing chamber, getting saturated with the vapor, and then comes back and joins the uh, main flow of the gas. Currently, Tech 7 vaporizer and corresponding counterparts are used for all agents except for desflurane, which is still a Tech 6 vaporizer. All vaporizers are push and operate. So unless and until you push the knob on the front and rotate the dial, it won't start. And if the setting is on zero, actually there should be less than 0.05% of gas going into the vaporizer and causing the vaporizer. It should be zero actually, but the minimum allowed is 0.05%. On newer vaporizers, you have got positions for zero, then you have got locking, and then you have got a transport setting also, so where you can tilt the vaporizer to more than 180 degrees. Now all the vaporizers are plenum type, agent specific, color coded with a specific filler. Uh, Tech vaporizers are temperature and pressure compensated. They are flow through except for a dust furane, which is air injector type. And dust furane has a parallel flow with heating system due to its high boiling point and an injector mechanism. So after the external heating, a small amount of vapor is injected into the uh, back bar and the fresh gas flow, and that is how the concentration of dust furane is achieved. Now, dust furane vaporizer is unique also in the part that it has external heating mechanism and a separate battery backup from the anesthesia machine so that it can be constantly used. In machines like ASS, the Aladdin vaporizer is used, which is a cassette type of vaporizer. Again, this is a plenum type only. Again, specific for agents. The only difference is that at the back side of this machine, vaporizer, there is a specific computer notation which is there. So the machine recognizes what agent is being uh, attached to the machine and how much the dial concentration can move for that gas. From common gas outlet, the gas goes to the breathing system. Uh, we can use open system. With the selective technique, we can use the open system for Mapleson breathing system. And the selector switch can be used to switch the channeling of gas into the closed circuit. The new workstation are unique in this as the circle absorbent can remain same for all ages. Uh, it doesn't have to change. They are called smart vent at least by Drager. Capacity is around 1.2 liter. And they use Dratsorb as the absorbent, which is uh, a high quality CO2 absorbent and doesn't form the compound A as in large quantity as the conventional soda lime would cause. Again, closed circuit in newer workstation can be used both for manual and mechanical ventilation. For economy of gas, fresh gas decoupling is provided in the workstation. For manual ventilation, APL valve is provided to adjust the breathing and allow certain flow to go through the circle absorber so that the fresh gas flow can be minimized into the system and economy of gases can be done. In the breathing system, or the closed system, the oxygen fuel cell is incorporated as a safety mechanism so that it's a usually a galvanic type cell which measures the oxygen concentration of the mixture. So this is the first and the best safety mechanism that the machine has to ensure that patient doesn't get a hypoxic mixture. It will always tell you what the concentration is. And usually when we start a machine during the pre-use check, the cell is usually, the person is usually asked to calibrate the oxygen fuel cell. Okay. Unless and until it shows 21% and 100% when uh, the breathing system is used and the oxygen is started, uh, it's not advisable to use the machine if you don't have any other monitoring system. Now, the currently available workstations have advanced flow and microprocessor controlled ventilator mechanism. They are both volume and pressure controlled mode of ventilation. Uh, all the modes that are found in ICU like SIMV, pressure controlled SIMV, volume controlled ventilation, pressure uh, guaranteed, regulated volume control, pressure support pro or pressure support ventilation, everything is available. So we can use them as we find suitable for the patient. And the ventilators are designed to deliver tidal volume from as low as 20 ml to as high as 2000 ml. Now, if you are going to use pressures volume of around 20 ml, it's usually only in the pressure control mode that 20 ml tidal volume can be sufficient. applied. So this is one of the things we should remember. Even though most of them say 20 ml, 20 ml may not be achieved on volume controlled ventilation. The added advantage in conjunction with the smart vent circle system is that we can use it for low flow, very low flow, as well as metabolic flow anesthesia. Now, it consists also of a spirometer and an airway pressure monitoring device. So on the with the flow sensor transducer. So all the information that is there is displayed as a waveform on the machine monitor. And important data is shown as either loops or graphs on the uh, display of the ventilator. So as I was saying, this is how the ventilator looks like. You can choose the mode. You have got volume controlled, pressure controlled, volume guaranteed, SIMV volume controlled, SIMV PAC, then pressure support pro. So pressure support pro is generally used for spontaneous breathing or somebody who is breathing on a second generation airway device. You can have a gas setup which can select what gases you want to give, what is the total gas flow, what is the percentage of oxygen, and other usual settings of the IE ratio, the rate, volume, or pressure, uh, the trigger, P, and the peak pressure. So everything can be controlled from the touchscreen on the ventilator. And the patient's actual parameters are shown on the right hand side as numerics. So in some machines, because of the modular nature, the anesthetic gas mixture is also shown as a part of the respiratory gas on this monitor, and you can know the map of your uh, anesthetic agent. You can have the inspired and the expired concentration of gases, both are there, which is very necessary when you are using it for uh, intermediate flow or a very low flow metabolic flow anesthesia. Because in during very low flow or metabolic flow anesthesia, the uptake of oxygen. So you have to know what is the inspired oxygen concentration and the expired oxygen concentration. Because we usually completely do not denitrogenate the patient. So there will be discrepancy sometimes. And if the difference between the EtO2 and inspired oxygen concentration is less than 6, that usually means that there is a buildup of nitrogen in the system and you need to denitrogenate system, which is simply means take the patient on hand ventilation, go on a high flow and denitrogenate your closed session and again come back to the low flow anesthesia. Monitors. Now monitoring in your machines is usually modular. So you have a basic mandatory monitor in one module, which will give you two ECGs, uh, an IBP, pulse oximetry, respiratory rate, and uh, temperature. So these will be connected to one, and others can be added as required if you want invasive pressure monitoring, a separate respiratory gas monitoring system if it is not available with the workstation, neuromuscular monitoring, this monitoring or entropy monitoring can be attached, and you can attach all other monitors that are there for nociception or some depth of anesthesia, pain that can be attached to the monitor. Advanced cardiac monitors like non-invasive cardiac output monitors or partially invasive cardiac output monitors can also be attached. Screen can be configured to around 8 waveforms and as many uh, figures. So you can choose what you want to see in waves and you can choose what you want to see as a numerical data that is to be displayed on the screen. Now, as I said, well, separate screen is provided for monitoring the ventilatory parameters. Here, the Both graphical and numerical pattern is used. And alarms to detect any abnormality like high pressure or disconnection are displayed on the screen. And these are high priority alarms, so you can set them uh, and use the anesthesia machine. Now, just to give you a brief idea of what are the safety features that are there in the anesthesia machine. So you have something for gas pipeline supply. So you have the pin index safety system, the diameter index safety system, the color coded flexible hose, the NISC connectors, that all goes to the machine. For pressure checkout or pre-use checkout, you have both automatic and manual checkouts that can be done. Uh, One thing we have to remember is that the newer machine have a pre-use checkout. Some steps can be bypassed in emergency, and few machines limit the number of time you can bypass a checkout. So ultimately, you will have to go ahead and do the complete checkout of your machine. For gas delivery, you have got a unidirectional check valve, fail-safe valve, second stage regulator, flow meters, oxygen flush, proportioning system, analyzers, failure alarm. Uh, in certain machines like Datex, you have Link 25 system, uh, sensitive oxygen ratio monitoring system. For vapor delivery, that is vaporizers, you have heat filler, colored coded uh, vaporizers, interlocking mechanism, and anti-spill mechanism. So in general, these are the safety features. Monitors also have a safety feature that there is a default monitor, and for certain parameters, you cannot set below the standard. Like if you are using a anesthesia oxygen monitoring system, it will not go below 19%. So as hard as we try, we cannot set it below 19. That's the default limit, and it will not accept, and it will give a high priority alarm at that time. Now coming to after we have done most of the things and we have seen how the workstation usually works, coming to the least uh, desirable part and least used part in the anesthesia workstation, that is scavenging of waste anesthesia gas. Now, it is desirable to vent out the exhaled vapor and maintain a vapor-free operation theater because of occupational hazards that it poses. Um, Most of them are seen in young females, like accidental miscarriages with high use of nitrous oxide, usually uh, vitamin B complex deficiency. All these are there. So, although not universally agreed, the recommended maximum accepted concentration on an 8-hour time weighted average is that the concentration should not be more than 2% parts per million for halogenated agent, not more than zero point 0.5 if nitrous is used in conjunction, or more than 25 parts per million for nitrous oxide. Now, WAG can be active or passive, both ways. So you can actively take away the gases from the anesthesia machine and uh, safely dispose it off into the atmosphere, or it can passively get disposed of via certain canisters of activated charcoal or zeolite crystals, which absorb gases and they can be reused again after reactivation. Now, there is usually an outlet in the breathing system which is separate from all the conventional 22 millimeters 22 millimeters male or 15 millimeter female connectors. There is a separate 19 millimeter connector which is used for this purpose for scavenging, and from there the gas can be adjusted and uh, led out of the system. The circle system also has uh, a waste anesthesia gas outlet at the back after the APL valve. So all the gases can be taken out. The active gas scavenging is usually either vacuum based or fan based, so gases are actively controlled, and it has four or five important parts. One is the intake port for the waste gases from the machine and the ventilator. Then you have a reservoir valve. You have positive pressure and a negative pressure release valve. Adjustment valve for uh, adjusting the suction pressure that is there to uh, scavenge the gases so that there is no undue change in the pressure of the breathing systems. Now, the scavenger interface is most important component in this, and it protects the breathing circuit from either excessive positive or negative pressure. So, the positive pressure is mandatory to vent excess gas in case of occlusion on the distal of the closed interface. And this is uh, more important to be present in both the active and the passive scavenging system. If active disposal system is used, negative pressure relief valve is also a must to uh, decrease any chance of uh, absorption of anesthetic gases into the waste anesthesia system. Now, reservoirs are highly desirable with active system because they can maintain certain pressure in the breathing system, and there will not be any damage or hypoxic gas which is going to the patient or unnecessary triggering of the ventilator. Now, coming to what the future holds for us in anesthesia workstation. Now, as I think of it, uh, most of the workstation will be now driven by technological advancement such as anesthesia and closed loop systems. This will make anesthesia more safe, accurate, and economical. With the advent of predictive and perceptive AI, many automated things will happen. Uh, the routine works like record keeping, predicting and preventing of adverse uh, drug reactions or any concerns in the patient will be decreased. You can individualize prescription doses if you're using a closed loop system, and you can monitor the patient's vital sign and decide preemptively when to engage in any rescue attempt. Now, AI programs from the machine learning and deep learning will lead to a system that are capable of performing other difficult tasks like anticipating patient's reaction to drugs used in anesthesia practice, recognizing the risk factor associated with complications, and even helping us and prompting us to manage anesthesia better. Now, these are certain systems which are there, which are already present. So, the future, as we say, is here. In some years, we might be using all these things. There's a diffuser system, which is a T for TCI pump, which is on a closed loop system. Drug deliveries to a closed loop anesthesia delivery system, and infusion pumps is already there. Max BP is a system which balances hypnosis, analgesia, and neuromuscular blockade through the monitors uh, through feedback loop. CDSS is a system which is for propofol sedation. You have got algorithms for delivering fluid boluses, those which are based on urine output, blood pressure, uh, MAP, etc. And you have for models for vasopressor titration, which are based on NIBP, the stroke volume variation. And maybe something like this in future can be seen on the machine that you enter your patient's weight, his ideal weight, uh, the name of surgery, and it will detect every other parameter. And if something like hypotension occurs, it alerts you that MAP has decreased by 40%, or the tidal volume is high, you need to decrease it. So it can prompt you how you can use your workstation in future. Now, the reason why all this is necessary is unless and until we are familiar with all these aspects of our machine, we cannot use them to their full capacity. As far as troubleshooting is concerned, in most of the new workstations, uh, there are hardly any troubles that are there because once you complete a pre-use check, it does all the tests that are recommended and that are taught to us when we were residents, and we tell our residents to do it. So tests like negative pressure check, the positive pressure check, everything is done. The battery backup is checked, how much is adequate or not, whether the electrical connections are proper or not. So everything is demonstrated before the machine starts delivering anesthesia. Very rarely, the anesthetist needs to do some kind of troubleshooting, and mostly it is in case if the patient is having some hypoxia, or as I said, if you are using uh, low flow or very low flow anesthesia, you need to understand that your monitors do have limitations. So you need to look at the monitors and understand what the monitor is trying to tell us and take corrective steps like switching back to manual ventilation on high flow for some time, then coming back. Understanding that if uh, that all mechanisms are not fail-safe. So if you still have a hypoxic gas mixture, is basically a crossover or something has happened. So you need to fall back on your emergency cylinders. You need to check your cylinders every day. You need to check their pressures. Are they adequate? Are what time they would be there? Uh, Second is, what is the battery backup for your machine and your monitor? So usually it's 30 to 60 minutes, but if you're using a ventilator, it will be around 15 to 20 minutes. So you need to switch it off. If there is sudden loss of power from battery as well as from the mains, you need to know that most of the new workstations have an auxiliary oxygen port, a button which you can activate, and a manual knob will pop out of the workstation, and start your you can continue your case for some time with the oxygen that is supplied by that uh, flow meter. So these are certain things. If anybody has any questions, I'm ready to answer after some time. I will now ask uh, Yogita ma'am, she has some important announcement to make. So I'll ask her to please make those announcements, and probably after that I'll answer the questions and I'll look at the chats. Yogita ma'am, please.
Good evening once again to all. I hope you have enjoyed today's webinar. And I want to announce that ISACon Maharashtra, Mumbai Metro branch is hosting the ISACon Maharashtra from 9th of October to 12th of October 2025 in Mumbai. And the venue is Westin Powai. And our website is functional, so you can visit ISACon Maharashtra 2025 for registrations. Early bird registrations we are finishing in 4 days. So I request all the participants, those who are interested, to avail the early bird benefit, and details of registration residential packages are already on the website. Soon we'll be updating the website, the workshops also. PG students have many interesting things to do, games, quiz, reels, and even we will have obviously posters and paper presentations also for the PG students, and lot many other things you can explore in Mumbai and around. So I request all the participants and people to avail the early bird benefit, which will be closing in day 4 of this month. So take the advantage of early bird registrations. And if people want to unmute yourself and ask few questions to Dr. Harshvardhan, you are most welcome. Otherwise, we'll take the questions whoever want to ask directly. So over to Dr. Harshvardhan. Any participants want to ask directly? You can unmute yourself. We are okay with unmuting and asking the questions. Even you feel it was not part of today's webinar, but you have some queries in your mind, you can ask those queries also. I guess very basic thing that every day the workstation should be checked before we do a procedure. So what do you think about that, Dr. Harshvardhan?
Uh, Madam, right now, whatever workstations we have or anesthesia machines that are currently available in the market for sale, usually will have a pre-use check automated into it. The moment you switch on the master switch, it will tell you to check the ventilator, the breathing circuit. It will do a negative pressure test. It will do a positive pressure test. It will tell you the compliance, and it will tell you what are the pressures of oxygen, nitrous, and other gases which are there on the machine. So once they are done, uh, so you can actually use the machine. They are very reliable. And the most important thing that we should understand is that, as I have said in my talk, that the only reliable source which would tell us that you are not going to give hypoxic gas mixture to a patient is your oxygen fuel cell, which usually is the most neglected part in the anesthesia workstation. So once the lifespan is usually around 6 months to 9 months. So once you buy that machine, usually it is not done, but on the saving side, we have our respiratory gas monitors, and I would recommend everyone to have the anesthetic gas monitor itself, not the CO2 monitor, but the module which has everything. So you can check the oxygen concentration that you're giving. You are checking the nitrous which you are giving, if you want to give, or air which you are giving, and what is the percentage of your anesthetic agent that you're giving. So that becomes mandatory for us to use and check and calibrate it regularly by having a service agent to come and do it for you. So that would be the biggest safety feature that is there.
There is one
Except
question.
Yeah.
How to check before starting the case? So is it before each case or starting of the day? This is I am my addition.
Uh, Usually, once you have done it, unless and until the machine is used or some uh, module is added or removed from the machine, or you are changing the uh, say your vaporizers from the back bar, it's not needed to do the complete test again. You can certainly skip certain parts like checking the ventilator system. Uh, so that's not required in the second case. So yes, some steps you can skip, but some are mandatory. So it is advisable as per the ASA guideline that you check before each case at least few things that are attached to the
મારે
machine.
રસોઈ કરજો એક જ
Continue, please. Dr. Harshvardhan, I guess continue. It was by mistake unmuted.
Okay. So obviously you have to do it every time. So basically, if you have changed the circuit test should be done again to check the compliance. Uh, so otherwise, if you're using the same circuit, maybe it's not required, as I said, because we are not changing the whole smart vent system now, which is common to pediatric cases, neonate cases. You're only going to change the breathing circuit, the diameter and the compliance of the circuit changes. So in that case, we need to check whether the circuit is properly functioning or not, and whether the sensors are working for the specific case, and you have chosen the specific case in the machine. So you have to configure your machine, whether it is for an adult, a pediatric case, or an infant or a neonate, whatever. You can add your weight of the patient, so it will automatically recalibrate itself to deliver certain uh, safety parameters into the system which are inbuilt. So we don't have to manually check it every time, because earlier what we used to do is generally do only a positive pressure test. Negative pressure test was very rarely done. So the machines now do that for us. So we don't have to rely on any external source. So that's the best part. And if the test fails for some reason, uh, one of the best ways to go and see is if the compliance and everything has failed or there is a leak, is to check whether your canister, which you have uh, filled maybe a day before, or you have just removed and realigned it, is the gasket and everything properly fixing? There is no leak from that system. So all this can be correctly checked, and once you are sure, the machine will adequately give you the result. Your compliance will come back to normal. Usually, it should be less than 300 ml, that is for adults, and less than 200 ml for a pediatric circuit. So if that is there, then we don't need to do any further checks on the machine. Yes, visual check for level of anesthetic agent in the vaporizer, that is mandatory for every patient, because how long you are going to use and which circuit you are going to use. So if you are using open circuit, probably you will require a higher uh, volume of anesthetic vapor. So in that case, you need to check those visually and do the adequate thing by refilling that system. But
So
for the
there is one
machine
more
part,
question.
uh,
Is it necessary to do a leak test every time?
uh, yes, and usually the machine does it. The moment you turn it off and switch it on again, it will do the test.
Yeah.
It will not go forward. As far as workstation is concerned, as far as uh, maybe a simple boils machine is concerned, a leak test is mandatory before every patient to take, because things, because we have all the sharps which are kept on the table near the trolley. So in that case, uh, I do suggest that you do at least a positive pressure leak test for your circuit, because the internal pipings may not be damaged. Once you have checked it for a day and the machine is stable at one place, but circuits do get damaged, bags do get damaged, reservoir bags. So checking them is necessary before each case.
Even in modern workstation, we get the amount of leak also visible. So
Yeah.
sometime,
So
ventilator functions with minimal leak. So we go ahead. Uh, this is little
yeah, so
manipulation we
that's
do.
why I said there is a certain amount of leeway that is given by a new workstation. You can bypass that for say around 10, 15 times, and maybe a 16th time it will say no. The machine will stop and say, okay,
Yes.
this check is not complete, and it won't go forward. So you can, and you cannot skip it also. So
Yes.
after some time, you cannot skip. So uh, it basically means that you have to look into that matter seriously. And as a personal thing, which we have done at Nair, we all our OTs have a backup machine which is kept ready. So we do have that kind of a system. So I understand it is not possible, but at least then to have a backup source for oxygenating the patient with 100% oxygen. So even a small cylinder with a flow meter of around 10 liters is a helpful tool to have on the machine. So that's what I would recommend for everyone, with an ambu bag uh, as per the case requirement. If you have an adult ambu or a pediatric ambu bag.
Harshvardhan,
Uh,
can I ask something?
yes, ma'am.
Harshvardhan,
Yes, madam.
yeah,
Continue, madam.
excellent lecture as usual. Acha, one more thing. Can you elaborate a bit on that master slave mechanism and link 25? Because that question was repeatedly asked this exam. And if both the test, which one is more important?
Uh, but a master slave mechanism is basically a pressure-based system in the intermediate pressure system. So where the pressure of oxygen pipeline, whatever the pressure is in the oxygen pipeline, that decides whether nitrous oxide will flow. If it is not a proportioning system, but a shut-off system. So if the pressure is below 25 psig for oxygen, no nitrous will flow into the system. Uh, so that is how it works. And in proportioning system, uh, the pressure of oxygen decides what pressure of nitrous oxide will be used to deliver, or what amount of nitrous will be delivered in the anesthesia machine. So it proportionally decreases the flow of oxygen. That is why it is called master. The oxygen becomes the master if it has adequate pressure. So if it is more than 50 psig, then only the nitrous uh, system is activated and nitrous can flow into the intermediate and the low pressure system. If it is not there, if the pressure is less than 30 for oxygen, there will be no flow of nitrous oxide. That is what the master slave mechanism is. And Link 25 system is basically a combination of pneumatic as well as a mechanical linkage. So the second stage regulator valve, as I said, which is just before the knobs are there. So the pressure is decreased for oxygen to 14 psig, and for nitrous it is to 26 psig after the intermediate flow, from the intermediate flow. And along with that, there are sprocket wheels which are attached to both the knobs. So in that, oxygen has 28 teeth and nitrous has 14 teeth. So the ratio remains at least 30% for oxygen. If you try to increase nitrous without changing the oxygen concentration, or if you decrease oxygen, it will simultaneously decrease the flow of nitrous oxide and maintain the percentage to minimum of 30%. So that is the Link 25.
There is one question in the chat box,
Okay,
which is
so
the idea.
more
Yes,
important
ma'am, we want to.
of the two, if you have to choose between one, which one is more important? Meaning, I would say both are important, but of the two, which will be more important?
Madam, the most important safety system probably is the oxygen concentration, which is shown by the analyzer. Because, as I said, both of these are based on the pressure rather than the content of the pipeline, either inside or the outside of the source. So, if there is a crossover, and say instead of uh, oxygen, there is air that is flowing into the oxygen pipe, and the pressure is more than 60, then also the nitrous will start. It is not going to stop. It is just a pressure-based system. So that are the limitations. But if you are saying the other things are normal, then probably the master slave or the proportioning system is better, because if my pressure of oxygen decreases, the amount of nitrous flowing into the system will also decrease accordingly. And that will at least give me some time to arrange and decide whether I want to continue with nitrous or I need to shut it off in case of emergency.
Okay, thank you.
There is one question in the chat box, which is the ideal position for a ventilator sensor or oxygen sensor? Is it at the patient end or the machine end? And also the ideal position for HME filter. So there are three questions in one question, so you can answer one by one.
Okay. The ideal position for anesthesia gas monitoring system, if I have, is near the patient. So if it is a monitor-based system to monitor the concentration of oxygen or carbon dioxide or the mixture of gas, it should be near the patient. So whatever he inhales or exhales at the point which is delivered is what is more important. As far as the machine is concerned, the oxygen fuel cell or oxygen analyzer is just before the inspiratory limb. So from where the ventilator will send the gas to the inspiratory limb, that is where the oxygen sensor or the analyzer is present. As far as the HME filter is concerned, again, HME filters should be kept. Uh, I presume that you're asking whether it should be before or after the monitoring device. Is that the question? Then it should be usually before the HME filter. But nowadays, what we get as HMA filters, they have a side port for um, analyzing the sampling of gas. So we can use it simultaneously. But if it's uh, inline measuring system, then it should be before the HME filter because uh, some vapor condensation will occur at that HME site.
I guess the HMA filter will be more concern in pediatric patients if we don't have a pediatric size HMA filter. Then sometime we do get a reading difference. So any recommendations for that, Dr. Tikle?
Then you should probably use the mainstream analyzer rather than the side stream one. So that's the best recommendation I can give for gas analysis. Otherwise, it should be, again, as I said, it should be near the patient. You can keep it at the T piece. So usually at uh, the shoulder of the circuit, most of the times we have uh, a mechanism where we can join the side port for oxygen analysis. So we can just put it there, and that will give you the best result in a pediatric case without increasing the weight. If you don't want to put a HME filter also, it will still work. And if you don't have a pediatric filter, you can obviously exclude it from the circuit so that the resistance and everything is not compromised for the pediatric or an infant case. So it
So
can be
many
put on the shoulder of the circuit.
yeah, many people even prefer at the expiratory limb also. So it
Uh,
will
well,
contaminate the circuit, but what is
well,
the
at
take on?
expiratory, if you put it on the expiratory limb, as I said, because we do not completely denitrogenate a patient, okay, 3 minutes of pre-oxygenation is not sufficient to completely denitrogenate a patient. And nitrogen is not sensed by any of the, at least currently available gas monitoring systems. So the reading will be faulty as there will be more nitrogen in that than near the inspiratory limb or where the patient at the patient end, just near the patient end or the tube. Because uh, during inspiration, at least because of the Coanda effect, you will get only the reading of the fresh gas flow. And same will happen because it's an intermediate flow system. While expiration, again, the Coanda effect will certainly give you whatever is nearer to the patient. It will have a difference for nitrogen always, but it will be less if it is at the patient end, not in the expiratory limb, because it expiratory limb will act as a reservoir itself. So it's better to be on the inspiratory side or near the patient.
What is your take on low flow anesthesia and minimum monitoring standards? Because quite a few of us are using low flow anesthesia. So, which monitors has to be mandatorily functional to effectively use low flow anesthesia?
Uh, if you are using low flow, uh, very low flow or minimal or metabolic anesthesia, it's mandatory for you to have the respiratory gas monitoring system. Without that, you should not be using a low flow anesthesia. So up to 2 liters, uh, yes, it's okay if you use only CO2 to maintain the and saturation which is there. That's okay. But if you are going to use anything less than 2 liters as a fresh gas flow, then the recommendation is to have a complete set of gas monitoring, and then only you can proceed to give low flow or a metabolic flow anesthesia. So that is the mandatory thing. Apart from your standard monitors, you have to have a complete range so that you know the exact concentration. If you are using vapor, in low flow anesthesia, since the vaporizer is out of circuit, it is not calibrated for less than 2 liters. So how do you set the dial setting to achieve a max? So you will need a reading to say what concentration of inspired agent you are giving and what is the expired gas agent reading and what is the MAC. That is how the MAC will be calculated. So if you are using low flow anesthesia, then your settings will be slightly more on the dial than in a conventional setting. So to check that, to correlate with that, you need to have a complete respiratory gas monitor. So you have to have inspired concentration, expired concentration of oxygen, of air, nitrous, and your inhalation agent. If you are using inhalation agent, if you are using a TCI pump, probably with closed loop system, you can just enter the patient's age, the target concentration you want, and you can connect a BIS monitor to your machine, and the closed loop will look at the BIS or entropy and adjust the dose of how the infusion goes at what time. So these are systems which are available, but what we use is we don't have a TCI. At least I have not seen in many places in India where target controlled infusion is matched with BIS or entropy, or is connected to that entropy with a feedback loop system. So we are presuming certain things. So if we have to presume, then also we need to know what is BIS. So in that case, you need a BIS monitor. But if you're not using target control infusions, if you're using vapor-based anesthesia, which is more common in our country, then respiratory gas monitors are more important.
I can't see any questions on the chat box, but if anybody want to unmute and ask questions,
No
uh,
questions. I just want to say that it was an excellent lecture, Harshvardhan, and I think it must have helped even the junior most resident to understand concepts.
Thank you very much, ma'am. Uh, I know this is not an ideal way to complete anesthesia lecture at least for the workstation, because I have tried to compress it in very short, because most of the things usually take uh, very long. Like if I take a vaporizer, there are different types of vaporizers which work
Right.
on different mechanisms. They have different uh, circuits. So all these things usually are taught to us and we are supposed to know. But because this was a lecture where I had to present a full workstation, so I tried to just club it in a very short and say, okay, what is currently available for us in the market? And thank you very much, ma'am. Anyway.
anyone else want to ask anything?
Someone is asking, will this be on YouTube? I think I
Mm,
Mumbai can answer that.
it is on YouTube. The link is shared. And once the recording is available, I don't know, you can message me, Dr. Mohan. I shall share the YouTube recording link with you. You can download the presentation. It will be available within 2 days' time. Right now, I cannot share immediately, but after 2 days, I'll get the YouTube, means the recording of the webinar. So I can share. You can personally message me if I'm not wrong. I'll share my mobile number so people can WhatsApp me or ask me for link. I need to click. Yes. So I've shared my mobile number. Dr. Mohan, you can contact me. So anyone else want to ask or we should call for the day? I can't see any questions. So I guess we'll take a off for the day. Thank you, Dr. Harshvardhan, for the excellent webinar and a very compact and important topics of workstation covered. And if time permits in future, we may plan another lecture for circuits and vaporizer for PG students. But yes,
Yeah.
the machines and the troubleshooting part was covered really well. I thank Dr. Charu Deshpande, Madam, Dr. Sona Dave for giving the opportunity to Nair Hospital and be a part of the webinar. And I thank all the PG students. I could see literally 84 people joining for the webinar. So majority of them were PG students and even few senior people I can see. So really thank you, all of you, for joining this webinar. And I hope we get a response in future also similarly. Once again, I appeal everybody to avail the early bird registration benefit of ISECON Maharashtra 2025, which will be held in month of October from 9th of October, which will be workshops. There are total 5 workshops we have planned. I'll just elaborate the names. Soon we will put it on the website. So workshops planned are POCUS basic workshop, regional anesthesia workshop, then chronic pain management workshop, advanced hemodynamic monitoring, and there will be a simulation workshop as well, and multiple scenarios will be covered in simulation workshops. So these are the workshops which will be held on 9th of October, and then 10th, 11th, and 12th will be the conference day. So I request everyone to please visit the website for ISECON Maharashtra and avail the residential, non-residential packages, whichever you are interested. And I really thank Dr. Harshvardhan for taking out his time. And I take off. So now, madam, you want to add anything?
Thank you, Yogita, for conducting this. And I really, this thing, request all the PG students to avail of the early bird, this thing, and take part in Mahaisakon. Thank
So
you, Yogita.
yeah, thank you very much, Sona ma'am. And we take off for the day. So good night, everyone. And good night, Dr. Harshvardhan and everyone.
Thank you, man. Good night.